Invite Dr. Vignesh to be here for his presentation.
Good afternoon all. My topic is the Eplerenone in the treatment of bullous variant of central serous chorioretinopathy. We all know that bullous variant is a little rare compared to other forms of CSCR. So this study was, the aim was to study the efficacy of Eplerenone in the treatment of bullous variant of CSCR. It was a retrospective international case series. 4 eyes of 4 patients with bullous CSCR who were treated with oral Eplerenone 25 mg once daily and had at least 3 months of follow-up were included in the study. Best corrected visual acuity, FFA, OCT at baseline were recorded, and the BCVA and OCT at the follow-up visits were also recorded. So all the patients were males. All the patients had complete resolution of macular and inferior bullous retinal detachment. 2 eyes had complete resolution at the 3rd month follow-up, 1 eye at the 4th month follow-up, and 1 eye at the 5th month follow-up. BCVA improved in 3 eyes and remained stable in 1 eye. 2 eyes had undergone additional micropulse yellow laser. The case 1, a 38-year-old male patient, left eye defect vision of 3 days duration, and BCVA of 6/60. We can see dense subretinal fibrin and also inferior bullous detachment with multiple leaks on the FFA combined angiography. So from baseline, like there was significant regression of fibrin as well as SRF with complete resolution at the end of 4th month. So at the end of 2 months, the leaks were reduced, so additional subthreshold micropulse laser also was done. The B scan from the baseline, the complete resolution was seen at the end of 3rd month, and the vision improved to 6/9. Case 2, a 42-year-old male patient, defective vision of right eye of 1 month duration, and BCVA was 6/6 partial. And there was a shallow fluid at the fovea, but however, there was an inferior retinal detachment, bullous retinal detachment seen. So that fluid, shallow fluid resolved, subretinal fluid, the macula resolved 1st month. However, for the complete resolution of the inferior detachment, it took 3 months. Case 3, a 41-year-old male patient, BCVA 4/60, defective vision of left eye of 1 month duration. History of CSCR 10 years back, treated with laser. So here, we did micropulse yellow laser along with Eplerenone from the baseline. And we can see a very good regression from baseline, like of the subretinal fibrin as well as SRF with a complete resolution at the end of 5th month. And B scan taken at 2nd month shows a complete resolution at the end of the 5th month. And the final BCVA improved to 6/12. Case 4, 38-year-old male, defective vision of right eye, again 1 month duration, BCVA of 3/60. So we can see a dense subretinal fibrin at the fovea with 2 leaks as well as the inferior bullous detachment. So from baseline, there was gradual reduction of the subretinal fibrin as well as the SRF. However, there was a residual subretinal fibrin that is seen subfoveally. So the vision improved from 3/6 to 6/24. The inferior bullous detachment completely resolved at the end of 3 months. So bullous variant of CSCR is a rare, atypical, and severe form of CSCR usually seen bilaterally in patients on long-term steroid treatment and organ transplantation. Characterized by multiple PEDs, cloudy subretinal fluid, dense subretinal fibrin, inferior exudative retinal detachment, and RPE tears. Eplerenone has been used in the treatment of bullous CSCR, previously 3 case reports have been published. In 2 cases, 1 case had a multifocal CSCR with low serum cortisol, and another case of bullous CSCR with giant RPE macro rip. In another study, Eplerenone was combined along with PDT in 1 eye and the laser photocoagulation in the other eye with a complete resolution. In my study, Eplerenone treatment resulted in complete resolution of bullous CSCR in all the 4 eyes of the 4 patients. 2 patients had been given additional micropulse laser. This is the first case series to show the efficacy of Eplerenone in the treatment of bullous CSCR. A larger study with a longer follow-up is warranted. These are my references. Thank you.
Yeah. Doctor, why did you add the micropulse laser? What was the indication that you added with it?
So actually, the first patient I had, there was a decrease in the leaks. I just did accidentally the FFA repeated. So because we were worried that patient was worried that it was not completely resolving. So when I did the FFA, so I could see that leaks had decreased. So initially I could not do because of the fibrin at the area of the leakage. So then when I added that, it augmented the faster resolution. So the aim was to make the fluid to go away as early as possible. So I had added micropulse, but other cases had significant decrease even without adding. So I did not add in the other 2 cases.
Did you follow up any of the cases after
Yes,
3
yes,
months?
they are under follow-up. Actually, because of the COVID, like two cases could not come for follow-up after the final resolution. So once they are completely resolved and vision is improving, they are not following up. That's the problem with the follow-up on the longer follow-up.
So you do not have the follow-ups of
No,
all
we
the
have
patients?
follow-up. We have follow-up, but not for a
Not
long.
all the patients.
Yes,
You
yes.
have 4 patients, so 2 you don't have.
Yes, yes. Two I don't have. So after the resolution, they didn't follow.
Okay.
Once you put a patient on Eplerenone, how do you track the course of the patient in terms of the drug? Any kind of blood investigations you need, or what are the expected side effect of this drug?
Yeah. So first, before we start the drug, we have to do a fission evaluation to rule out any cardiac disease, hypertension, as well as serum potassium levels has to be taken because it is a potassium sparing diuretic. So the potassium has to be below 5 to start the drug. And then once I start with the 25 milligram OD once daily, and I explain to the side effects like dizziness, giddiness, muscle pain, and chest pain to the patient. And once they develop, they have to stop the drug and report to us immediately. And then I follow up every month and repeat the serum potassium along with the OCT when we do that, repeat the serum potassium. And if it is any increasing beyond 5, we stop the drug. So then maybe those cases will need additional laser, but none of my cases develop that hyperkalemia. So it could be safely given 25 milligram. Once we make it 50 milligram, like the Western literature says for chronic CSCR, we may have more case of hyperkalemia in Indian patients. Maybe their the dosage required for Western population may be higher than the Indian population.
So that needs a bit of caution that it cannot be given unsupervised. You cannot leave a patient on Eplerenone for 3 months and 4 months. So one has to be there. And the pictures which you have shown, it might be a thought that just came in my mind, that idiopathic bullous CSR which we see, usually they don't carry fibrin. Usually such kind of pictures are not there. So was there any specific subset of patients you choose? Because whatever idiopathic CSCR what we label, they never carry this kind of fibrin. Multiple leaks are usually not there. So is any secondary cause of fluid in these patients? Did you explore or did you rule out? Because these pictures are classically not the idiopathic CSR. Do you agree?
Yes, so actually only one case had a history of steroid intake before, but it was not very clear history. He was not able to tell that because he had lost all these reports. So that was the only in one patient alone. So other patients didn't had history of CSCR before. So actually 3 patients had history of CSCR before.
So it is very ambiguous. We have 4 patients and all are of different subsets. And what you call CSCR, that has to show on an OCT a leak or a smokestack pattern or something like that, or a pooling of dye somewhere in a PED, but never these multiple kind of things. And it looked more of a secondary kind of thing, and exudation and fibrin coming in, usually not seen in an idiopathic CSCR. So do you advocate Eplerenone in an idiopathic CSCR, or you define the usage of this drug in a very particular subset of patients?
No, this was only the common thing in all the 4 cases was subretinal fibrin and inferior bullous detachment. So however, I use Eplerenone in all cases of chronic CSCR. So wherever we have bilateral cases with multiple leaks, I usually do laser. I usually give Eplerenone. But if there are unifocal up to 2 or 3 leaks, I do laser.
Should we reconsider giving the topic of usage of Eplerenone in a recalcitrant or a resistant CSR rather than a bullous idiopathic CSCR?
No, in this series, the problem was we could not do laser in every case because of the fibrin, because the laser may not penetrate deeper to act in these cases. So the Eplerenone will be a better option in this case subset of CSCR where there is dense subretinal fibrin above the leaks.
So this is what we learned, that if there is fibrin and exudation and it's a recalcitrant case, you are not able to do laser, then you can think of an additional therapy in the form of Eplerenone. That is good. Now we have filtered out.
Yeah, okay. And in your second case, you have shown that visual acuity, it was only 6 par.
Yes.
And fovea was also not involved, and there was a small detachment. No? So in this case, there would have been different option, I think.
But there was an inferior bullous detachment was there. So patient had a field defect. Yeah. So I gave first laser along with the Eplerenone.
Is there any chances of spontaneous
Spontaneous is I have seen in 2 cases where we could not give Eplerenone because of the systemic abnormalities. Patient had renal failure. So those cases I have not included here because the patient having long-term renal failure cases or cardiac problems or already having some potassium abnormalities. So those cases we could not give. So one of the patient, like I just gave Nepafenac only, just to be on the safer side, just for anti-inflammatory role. Whether I'm not sure about that, but then I followed up the case, and then that case resolved in 3 months' time.
Okay,
So
we'll
that also is a
conclude
possibility.
because
So but whether we could have an observation of in this series is a question.
Thank you,
Thank
Dr.
you